everyone. This is good. This is going to be so good. I am so excited to have Dr. Kim Einhorn here, who is a phenomenal, and you guys will figure out, you understand why I say so. Phenomenal board certified OBGYN and exceptional menopause specialist. And today we're going to be talking about this critical, life changing topic that apparently 50% of the entire world goes through and not enough people talk about. So,
Yes,
so good
51%.
to have you. 51, there we go. So good to have you here today, Dr. Einar. How are you doing?
I'm fine, and thank you so much for having me. I've actually been looking forward to having this chat with you.
Likewise, likewise. So tell us a bit about yourself. You have this incredible practice, which we're going to talk about as this conversation goes on. But tell us a little bit about yourself, what you do, and how you ended up here, because your practice is pretty unique.
Well, so I, went through medical school, did my OBGYN residency, and spent about the last over 20 years just doing full scope obstetrics and gynecology. So taking care of, women from puberty on through post menopause. And I would say that gradually over time, as doctors age, our patients age with us. And I suddenly one day found almost all of my patients going through perimenopause with me. And I think it's a pretty common theme and story that you hear out there, that most of us don't really know much about menopause or perimenopausal care until we're really faced with it in the practice, or when we go through it ourselves. So for me, it was my patients going through it before, and I felt a little bit, I would say, like ill-equipped to handle it. And I do remember, it was really back in 2018 that I started developing more of an interest in taking care of women. And after I would see how much like you could really improve their quality of life and make them feel amazing and get kind of like instant gratification and quick results with hormone therapy, which is what OBGYNs like. I really began to take a special interest just in that phase of a woman's life and midlife, and learning how to really navigate the ins and outs of hormonal therapy, non-hormonal therapy. And that kind of really took over. I really kind of fell a little bit, I've always really loved obstetrics, but I became enthralled with menopause and perimenopause. So left my old practice to open up my practice here, which is really just specializing in midlife women's healthcare through like the menopause transition and beyond. And that's what I do all day, every day here.
And I mean, and your practice has just been so phenomenal. It's like I said, you like hit the ground running. How long have you been open now?
Since October, we bought this
Wow.
property and we renovated it from, this used to be like a very rundown building in a really nice little section of Bryn Mawr, right across from Bryn Mawr Hospital. And we made it into, one of my patients calls this the She Palace. And it
Oh
is
my
just like,
God, I love it.
so do I actually. I mean, if I should do a video tour around here one day, but it's a special place. Like women feel special coming in here. And I think they feel like they're in a place where their doctor cares about the experience they have, and to make them comfortable. I tried to make it a little bit less like a hospital, or like an medical office building, less clinical,
Yeah.
and just more like a little bit more comfortable, take a little bit of the edge off of the exam you might need or something like that. My last practice, we had like a terribly rundown office, to the point where some of my patients would actually comment on it, and there was really nothing we could do about it. So when I built this place, I had it in mind that this was going to be someplace that was going to be a nice experience and a nice place that people and patients would want to actually come.
And I think that makes so much sense, right? Because this is a very, well, it doesn't get any more personal than that. I feel like sleep is vulnerable, but gynecologic care, menopause, it doesn't get any more personal. And so it's beautiful that you've created a space where women can let their guard down a bit. Because you're right,
I
a lot
hope
of those other practices look so sterile,
they do. I
you
mean,
know.
there's a reason why women's blood pressures are completely elevated before they know they're about to have a speculum exam, and have like an exam that really does put you in a really vulnerable
Hmm.
place where it's an invasive exam. It
Yeah.
can be uncomfortable. It's
Mm.
certainly vulnerable. So anything to take the edge off. Like we have some lavender grass cloth wallpaper up in the exam room.
Oh my God, I
And
love that.
patients like that. So maybe it takes the systolic blood pressure down just a little bit.
I love it. That's awesome. So let's get into this. So when I invited you to just come talk to us honestly and teach our people, um, really, right? People, there's so many terms you hear thrown around, right? There's your mid 30s, your mid 40s, your mid 50s, your mid 60s. There's perimenopause, and then there's menopause. There's midlife. There's hormonal change. There's just so
So
much out there. So maybe just break it down for us. Like, what is perimenopause? What is menopause? When do we anticipate this starts? And then we can move on to say, like, are we in menopause, perimenopause? Like for
right.
that woman who's wondering.
Right. So just to break down the basics, menopause is has a specific definition, and that is when you have gone without a period for 12 months. Then you're in menopause, and that's where you really stay for the rest of your life. Whether you call it menopause or postmenopause, it's really the same thing. And then perimenopause has a specific definition of, the early phase of perimenopause is the time when your periods start spacing out or coming closer together in interval. Basically, the interval changes of 7 or more days. And then the later phase, like for instance, if you had a 28-day period and now you have a 21-day cycle. And
Hmm.
then the later phase of perimenopause is when you start skipping 60 or more days at a time regularly. Then you're in the later phase. However, we know that symptoms can start well before you actually fit that actual criteria definition. So, I do think that it's definitely a misnomer to say that your symptoms, that you're not in perimenopause because you don't fit the period criteria, because we
Yeah.
definitely know, we even have data from the Swan study that where we see, symptoms can start up into like as early as the mid 30s. And I see that all the time in my practice. I
Wow.
have patients here in their mid 30s.
That is, and I thank you so much for highlighting that because this is what I've seen. I've had, because I see a lot of women in midlife as well. And I've had them say, well, I asked my doctor and they said, no, it's not possible because my periods are not yet irregular or I'm still
Right.
having my periods. And I think this is so important to understand that you can actually, the period criteria may not be met and you might actually be in perimenopause. So maybe talk us through what these symptoms are, that
Yeah.
women should expect, especially during this stage of life.
I mean, they're wide ranging, so I would talk about that. But I do see what all the time. I'm generally not someone's first stop. I'm sometimes their
Mm,
third doctor, their fourth doctor after they've been to their
wow.
gynecologist, after they've been to their primary care, and
Hmm.
they have been told that they can't be helped, that hormone therapy they're not an option for, because they don't have the typical symptoms, because they have periods or regular periods still, and they don't have the typical symptoms that we would associate with menopause, which are the hot flashes and the night sweats. And I even
Mm,
have patients that when I ask them if they're having hot flashes, they'll even say no, because they think that hot flashes means they have to be waking up in a pool of sweat, when really that's actually just what a severe hot flash is. But there's mild
yeah.
hot flashes too, which is because my second question is, are you throwing the covers off and on at night? And as a sleep
Mm,
doctor, you're probably hearing that all the time.
hmm.
Even if they're throwing the covers off and on at night, that's a hot flash. And so, there are those which are the hallmark, and patients and doctors together recognize that those
Yeah.
are symptoms. But what I see really early, starting extremely early, are the mood symptoms. And I think the most
Mm,
common, women will identify as having like exaggerated PMS symptoms and irritability and a short fuse, what they describe as just they don't have patience anymore for their children, for their husbands, for people around them,
right.
and they even will describe it as rage. So I find that to be probably one of the earliest symptoms that I would associate with perimenopause, even if they're still getting regular periods, because guess what helps them? Hormone therapy. Either that's
Mm,
in the birth control pill or in traditional menopause hormone therapy. But, it's not like just one day our ovaries stop producing
mm,
estrogen, or one day they just start decreasing the amount of estrogen. It's just on a continuum of gradually, day by day, week by week, year by year, your ovaries do produce less. So that's going to cause not necessarily the definition changes in the periods that you see defining perimenopause, but like differences in the period and differences in your mood and your PMS symptoms and things like that. So commonly I hear patients say, oh, well, my periods get really heavy for the first 2 days of my cycle, and then they abruptly stop and trail off for spotting for
mm,
a few days. And that was never like that before. So that's a change caused by your hormones changing.
mm. That's so good and so important to know. So Tell us about, and then that's the other piece I've had people say, like, well, I'm on birth control pills, so it's, or
Yeah.
birth control, any formulation. And so I don't even know if I'm really, if is it my periods that are declining? Is it because I'm on this birth control pills or birth control medicine or whatever? Like, how do we make that difference in that situation?
So, if you're on a birth control pill, you
Mm,
definitely are already on a form of hormone therapy. Now,
yeah.
maybe you won't necessarily know what stage you're in. And is it really important to know? Maybe not. Like, as long as you're
Mm,
feeling fine, then does it really matter if you're in perimenopause? Like, does it matter? I mean, so I do sometimes find that women on the birth control pill will sometimes have symptoms that break through that. Because while the birth control pill is really good at suppressing your ovulation and suppressing symptoms as far as PMS, sometimes it's just not enough, because really perimenopause is the time when our ovaries go a little off the grid, and you can have like your ovaries are still doing what they want sometimes despite taking the pill. So sometimes
mm,
you'll still have symptoms. Sometimes the form of estrogen in the birth control pill isn't the best one to take care of menopause symptoms. It's like ethinyl estradiol is the most common form of estrogen used in the birth control pill, and that might not be the best estrogen to help with the menopausal symptoms. So sometimes women will come in feeling poorly even though they're taking the pill, which is actually high
mm,
dose hormones compared to menopause hormone therapy. And then
yeah.
it's just a matter of either finding them the right pill if they need birth control, or then putting them on some sort of menopause hormone therapy, which is usually very successful at curing symptoms. And I also didn't mention the other symptoms that for your last question. It's not just mood, but it can be the cognitive things, the brain fog,
Mm,
the word recall, the forgetting why you walked into a room, forgetting acquaintances' names, or recent conversations you just had. And a lot of my patients are become very scared of dementia happening
yeah.
like at an early age. But there are very, very hallmark cognition signs for perimenopause that really have nothing to do with dementia. It's pretty easy to sort those out. But women will feel muscle aches and joint pains, and they'll feel low energy because they're not sleeping as well. This can lead to
Hmm.
chronic fatigue. It really, the dry skin, of course, wrinkles, definitely the weight gain is a huge one. I think it's right up there with the mood symptoms, and especially weight gain in their bellies where they never had that before. So there's a lot of changes that happen, and it can happen well before. It can definitely start before you start missing periods or having hot flashes.
So thanks for highlighting that, because literally it almost seems like from head to toe,
Right. It
it
is.
impacts
It's
pretty
from
much
your
every
it's
system
from your hair to like
to
the
your
joints
toes.
in your
Yeah,
knees
because
and
you're doing
yes.
exactly. So that is so powerful. And I know I've had people refer to estrogen as sort of the workhorse of the workhorse hormone for women. So what are the hormonal changes that typically occur during this stage of life?
So during premenopause, you're
Yeah.
ovulating regularly, and you have hormonal fluctuations, but when to expect the rises and the falls, and it's predictable, cyclic every month. So, women can get PMS because they still have fluctuations. That's what our brain doesn't like, but you at least know when to expect it, and there's a regularity to it. Then in menopause, that changes, and it's kind of like a smooth, I think of it like a smooth, calm lake. You know that your estradiol levels are going to be relatively low, and they stay low, and your FSH levels, that's the hormone that comes from the pituitary that acts on the ovaries to get the ovaries to put estrogen out, that's going to stay high because it's constantly trying to get the ovaries to produce this estrogen. But in perimenopause, it's a completely different ball game, and you have higher highs of estrogen than you had before you were in
Mm.
perimenopause. You have lower lows, and it's completely unpredictable. And you can even have what's called a loop cycle, which is when your pituitary really coaxes your ovary into ovulating twice in a month. So you'll have double or triple the amount of estradiol that you're used to, and you can feel irritable and have breast tenderness and angry and not sleeping. And then a month later you're in a menopausal estrogen level, and it's just kind of goes on like that for years until you're finally in a stable place with your hormones in menopause. So and this is one of the reasons why I tell patients it's not really like the end all be all to get your hormone levels checked. And, a lot of women are very, very focused, laser focused on knowing what their estrogen and progesterone
Yeah.
levels are. And I don't really ever die on the hill of not checking hormones, because I don't have a problem with knowing the data, and I don't have a problem with the patients knowing the data, but knowing that I can't use that to diagnose your perimenopause. And sometimes it even backfires. Patients will come into their doctor, and their doctor
Mm.
will check their hormone levels, and they would happen to catch them on a day when their estrogen levels are normal. And then they'll say everything's fine, you're not even in menopause, like go home. And they will go home without even
Mm.
getting treated and feel horrible for another year.
Oh, that is so, thank you so much for bringing that up because that's a thing. I feel like it sounds like there may be a role, but we don't go by that piece of data because it's a one point in time. So
Right.
depending on what stage you're at, your level may be normal, it may be high, it may be low, but really takes listening and seeing if you meet the criteria based on the symptoms you're having.
Exactly. I
Yeah.
mean, there, like, we know there definitely is, there definitely is a treatment
Mm.
to cure symptoms and to
Yeah.
ameliorate symptoms. And I treat until the symptoms are at a level now where you feel good again.
Yeah.
So if
Yeah.
estrogen makes you feel good, if you feel where, like, I feel like I'm back to normal again, you're at a good place, you're at a good dose. If you still feel like you're still suffering with symptoms that made a little bit of improvement sometimes, then we change it. We can
Yeah.
increase it. Sometimes the estrogen is like a little too much, so we have to go down. But definitely you
Mm.
just treat until the patient feels like she's ready for the world again.
Yes, ready for the world. That
Yeah.
sounds good. So why is it important? Why should women not suffer in silence? Because again, I feel like there's been a lot of gaslighting. It's been
Oh.
attributed to stress. Yeah, go manage your stress or go treat your anxiety or why is it important for women to know that there's help and what would be the benefits? I mean, clearly I want to feel good, but even just overall health long term of addressing some of these symptoms.
Well, I think that women are so it's a complicated answer, because I think societally, like, women
Yeah.
are a little bit um gaslit to think that,
Hmm.
they shouldn't complain, or that they are too complaining, or that they're hysterical. And it's almost like there's a thinking, and treating women for like my whole career, I see this. It's
Yeah.
like women come in all the time and they say, well, it's not that bad. Like, sex isn't it's not that dry. It's not that painful. And therefore they don't think they deserve treatment. When really, if you think of it, most male counterparts are absolutely, like, not suffering in silence and not saying it
Yeah.
has to get really bad before I seek a help and therapy. So I do see women as being A, very strong, and B,
Mm.
very stoic, and C, very conditioned to not complain about things, and to think that they're only entitled to seek therapy when it gets bad, when it's that severe that they can't even go on anymore. And I think
Yeah.
that thinking really needs to change. I think women need to understand that, like, they should seek therapy at a point when they feel like this isn't good for them. And it doesn't have to be terrible. It should just be like, like, it's always a good idea to go for a consult to speak to your doctor about it, but it doesn't have to be severe. It just has to be something that they need improvement on, something that they feel like
Yeah.
isn't right and that they think can be improved upon. And there are, obvious short-term quality of life benefits to being on hormone therapy. Like, obviously, when you're having hot flashes and you're not sleeping at night, as sleep affects everything. And, there's a downstream effect from not getting sleep. You are, metabolically changed because your cortisol levels are higher. You become more insulin
Yeah.
resistant. You're searching for more food from, you're eating more often. You're searching for more energy sources from food. You're looking for carbs. So you're gaining weight. Gaining
Yeah.
weight, then you're exercising less. You're tired, you're not exercising as much. So you become physically less healthy. And it
Yeah.
affects your mood, it affects your cognition, so it affects everyone around you too. So
Mm.
the short-term quality of life benefits are real. And then we know long-term, like, systemic estrogen has an FDA indication to prevent osteoporosis. So for my patients that have a family history of hip fracture, of osteoporosis with their mother, they have a reason to even be on it if they have osteopenia or they're at risk. And then, it remains to be seen. There's a lot of observational data and some RCT data that does point to apparent cardiovascular benefit from hormone therapy when you start at a younger age. Generally, they say a
Mm.
10 year window for menopause. And then, new studies need to be done. Like I know Dr. Lisa Mosconi is starting her, is starting large trials on estrogen and how that affects the brain and dementia risk and things that, have yet to be proven. But there are potential long-term benefits. And even if you use vaginal estrogen, it prevents 80% of UTIs as we get older. And
UTIs.
yeah, UTIs in the 70s and 80s, that can be fatal.
Absolutely. So many. So short-term benefits and actually long-term benefits, even to the point potentially of, heart health, bone health, brain health, so many
Right.
things again. Now, for that woman who is like, well, I had a history of, maybe breast cancer, or again, some of the older studies, I think that's the issue, right? Some of the older studies that were not well conducted that
Right.
showed some evidence that, oh, yeah, maybe hormone therapy can increase, you know,
Your risks.
all kinds of risks. So maybe talk us through what do we know now to really provide that reassurance for someone who's still on the fence and is still a bit worried.
So I do spend a lot of time in my office counseling and talking about those specific studies, namely the Women's Health Initiative. And this
Yeah.
was a very large randomized control trial, the largest of its kind still to date, that really had the effect of scaring everyone off hormones. Women, most, I think it was 80% of women used to use hormone therapy for their symptoms until the 2002 publication came out in a press release. And it really did say that hormone therapy was going to increase your risk of breast cancer, heart attack, stroke, and dementia. And the problem, I mean, it's probably a little bit too much to go into all the nuts and bolts about
Yeah,
that.
of
But
course.
that study was criticized from the get go, even among the authors of the study, because the breast cancer risk was what really scared everyone, and that actually never reached statistical significance. This is like the statistical number to show that this is a real thing, a real risk to women. And in the reanalysis, when they actually looked back at the numbers and they they it gets a little complicated, but really, let's just say worst case scenario, if you just take the WHI data at face value, it was one additional case, or I should say 8 additional cases per every 10,000 women users, 10,000 women that use
Wow.
hormone therapy, which is less than 1 per 1,000, which equates to 1% increased risk in breast cancer. Now, if I was suffering terribly with symptoms and you told me that my risk of breast cancer was like 1% versus like maybe suffering and then understanding all the downstream possible benefits of hormone therapy, I wouldn't be so scared. But it was expressed not in terms of absolute risk, which was that 1%.
Mm,
It was expressed as a 25% increased risk in breast cancer because they used a term called relative risk.
mm,
Understanding that, like, in the statistics world, 4 out of every 1,000 women on placebo will get breast cancer, but five out of
exactly.
every yeah, but 5 out of every women using hormone therapy will get 5 out of every 1,000 women using hormone therapy will get breast cancer. So in terms of relative risk, that's 25%, but in terms of the actual numbers, it's less than 1%. So I do explain all that to my patients. And then I also say, but in the Women's Health Initiative, they used older women. The average age of the participant in that study was 64 years old. They
Wow.
had women that were 79 years old in the study. That is not the typical age of women that are coming in seeking, care for their symptoms, that are in their 40s and 50s. And they also used a specific type of estrogen and progesterone. And, so the oral estrogen poses more risk than transdermal forms that we use today in terms of heart attack risk and blood clotting risk. And the type of progesterone that we used has been linked to breast cancer and blood clotting more so than the bioidentical forms that we use today. So you can't really, you can't really generalize the results of the Women's Health Initiative to younger women and the current forms of hormone therapy that we use now. So that was a long-winded answer that I apologize for, but that's kind of how I go about
That's
it.
okay. I love it. I think that I feel like it's almost like the elephant in the room. Like literally. I feel like because we have to earn trust, right?
Right.
When we want to offer this. And there's so many studies that like you said are coming out just to show just the benefits and just really thank you for providing that clarity. So okay, you've convinced that lady that's listening, and she's like, okay, Dr. Kim, next, I'm ready. What are the next steps? Now you've figured out
Oh,
I am in
then
perimenopause
I
and the hormone therapy thing. I feel much more confident. What now? What now? Help
well,
me.
then I break out the bowl, and this is the bowl right here.
Oh,
So
oh
this has
wow.
like I'm really proud of my bowl because it took a lot of like
I love it.
nagging pharmaceutical reps and prescribing own different forms to myself to like come up with all of these like things that I can actually, physically pick up and show women and lay them out on my desk
I
and
love
show them
that.
all the options, both hormonal and non-hormonal. So, you mentioned patients
Mm,
that have had maybe like, the breast cancer risk. I have a lot of patients that come in here having had a personal history of breast cancer or
mm,
a blood clot or a heart attack. And, they may not be candidates for estrogen. So I show them
yeah.
the non-hormonal, we have very good non-hormonal remedies that we never used to have all through my whole career. And they're
Mm,
working wonders for patients who cannot take hormone therapy. They're not really, they're not for women that can't take estrogen because they're not going to get approved by their insurance. But there
yeah.
are there are patches. There are little sprays that I use, estrogen sprays. There's like oral pills that you can take. So there's like so many different ways to get estrogen in your system. And there's also different ways to get progesterone in your system. Generally, we start with like the micronized progesterone because women like to get, I think a lot of women notice a sleep benefit from that. So I
Mm,
kind of present all the different options to them, see what fits what's going to fit in their life, what they have a liking for. Look at their personal medical history and family history, what might be better and safer for them. Some like, for women that are high risk in breast cancer, sometimes I recommend one versus another. And so then we kind of just go from there and we work. And then after that, we give them a few months to see how they feel on that. And then we work on, is the dose right?
Sounds beautiful because I love that there's so many routes. So how do you figure out what formulation is best for who? Like, is it just a choice, like a conversation you have with them, or
It's just a
yeah,
conversation. Unless I think
okay.
that they have certain medical conditions that will make them, let's say, not a safe candidate for oral estrogen, because oral
Mm,
estrogen is on the table for most women. But like,
mm,
let's say they're not, they do have certain medical conditions that they're not safe for something. Then I take those off the
mm,
table. And I really
okay.
do let the patient decide. It's up to them. Like they get to decide if they want a patch, or maybe they don't like a sticker on their skin, or maybe they don't feel like they want to remember to put a gel on their skin every day and a patch is going to be easier. There's a lot of, it's mostly just them deciding after I give them give them what is going to be safe and good for them.
Yeah.
And then I usually, start younger women. I don't think that they're going to need the lower doses. I don't really waste a lot of time starting on the lowest possible dose. I give them a dose that I think they may not end up on, but if you start someone too high, they might have symptoms like side effects that is going to turn
Yeah.
them off estrogen. And if you start them too low, it's going to take them forever to feel better. So I usually try
Yeah.
to get a dose according to what their symptoms are, how old they are, and what they're really looking to get out of it.
I love that. I love how you customize it. So, is it everybody that gets on estrogen and progesterone, or do you have people who are just on progesterone, or people who are just on estrogen, or I think it all sounds like it all just really depends on their symptoms.
It's actually such a good question. So the only people that can be on estrogen alone are women that do not have a uterus, because estrogen alone, and we found this out because like the history of hormone therapy was that everyone was just on estrogen. That was hormone therapy. And then we found out that estrogen alone after years can give you uterine cancer. So everyone that has a
Mm,
uterus needs to be on some sort of progesterone agent or a progesterone-like agent or an IUD that contains progesterone.
mm,
And we
okay.
really do use estrogen to cure it is the workhorse. It cures the majority of symptoms, but you need the progesterone mainly for uterine protection. However, I always do start one at a time. And generally, that is usually the progesterone first because like I like to know what's causing what symptom, what's curing what symptom, what's causing what side effect. And sometimes
Mm,
estrogen hormones can overlap with side effects and symptoms. So I usually start one at a time, and that's usually the progesterone first. And sometimes women will absolutely notice a difference in their sleep and even an improvement in their hot flashes and their mood. And then I start them on estrogen after a certain time. And every once in a while, I have a patient that absolutely was like, I felt like $1,000,000
mm,
on that progesterone. And ever since I started estrogen, I'm just more irritable and I don't like it. So they stay on progesterone
mm.
alone. You know what I mean? If they're at risk for osteoporosis, I tell them we have to get you on some form of estrogen that's going to protect your bones, because progesterone doesn't do that. But most women do take estrogen and progesterone together because they have a uterus and they need the estrogen to cure the majority of their symptoms.
Okay. I love that. So good. This is y'all told you see what I said. This is
Yeah.
why I said Dr. Kim's the expert. I love it. So good.
I love it too. Sometimes I feel like maybe I do complicate it a little bit for patients. There are some patients that kind of they just want you to like simplify it a little bit, tell them what they should be on, and I
Yes.
do that. But I
Yeah.
do believe that like women are so smart, and they do have
Yeah.
preferences for what they want to be on. And when they're just given all the information, they do come to like that perfect decision for them. And then we just kind of
Yeah.
tweak it over the year.
Yeah. Yeah. And I just love that. It's also empowering to know that they have options, right? And I think
Absolutely.
that's beautiful. So tell us for what are the non-hormonal options? So for that woman who's like, well, I'm still on the fence, I don't know.
Well, there are, okay, so for women that really need relief of symptoms and they can't take
Hmm.
estrogen, I have the non-hormonals. I absolutely, I feel like we're so blessed to have them. And one is Linquet and the
Yeah.
other is Veoza. These are what's called like NK3 receptor agonists. And
Mm,
they non-hormonally stop hot flashes and have really good sleep benefits, separate sleep data, especially with the Linkette. Although Linkette is a
mm.
gigantic pill, and if you can't take pills, if you're not good with pills, you cannot take this. That's the one drawback that I've seen. This is a big pill.
Oh my goodness, that's a horse pill.
It's a whole pill, and you have to take two of them. I mean,
Yeah.
like it's not everyone that can take that pill, but
Yeah.
it has a little bit better sleep data than the Veoza. And then
Mm,
for women that just are kind of on the fence, most women that come to see me are already like, just give me the hormones. But there definitely are they're less likely to cure your symptoms, but there are like
mm.
phytoestrogens. One that I
Yeah.
like that I used to prescribe was called Relazin. It's a tree pollen extract. But I really do tend to like err on the side of telling women that if you're having any kind of symptoms that are like even moderate to severe symptoms, you probably are not going to get the relief that you need
You
from
need.
just taking a tree pollen extract.
Yeah.
But like, of course, lifestyle pillars are important. Like I've worked out with many trainers in my life, and I tend to notice that they have very mild symptoms because physical fitness is big when it comes to like how
Yeah.
severely you're going to experience your hot flashes and your vasomotor symptoms. So optimizing all the lifestyle pillars like we have to do with so many breast cancer patients,
Mm,
that makes a difference. Moving to help alleviate the joint aches and muscle pains and things like this. That like eating foods that are rich in soy helps. Making sure that you're avoiding triggers for hot flashes like alcohol, and sometimes it's even sugar for women. So alcohol is a sleep disruptor, so we want to do anything that's like not going to affect their sleep. So I would
yeah.
honestly say it's just like the lifestyle pillars of exercise, sleep, if you can try to get your sleep in other non-hormonal ways,
Yeah.
and exercise.
I love it. I love that. I love how you rounded it up nicely with that because I think that's another area that we want. And I would dare say, at least from a lot of the women I see who maybe have been on, they're already on hormone replacement therapy and they're still symptomatic, they're still
Right.
exhausted and all of that, is really lending yourself to making sure that you're optimizing all those areas. Because if you have sleep apnea or you have insomnia or you have restless leg syndrome, or you're
Mhm.
still eating a lot of spicy meals and drinking alcohol, well, there's so much. The hormone therapy is not like a magic pill that's going to fix all the issues. We still have to establish those healthy habits.
Yeah, it's actually why I
Mm,
went against smarter people. I mean, I'm happy that I have it now, but we built like a studio, like an actual gym
mm,
in the practice downstairs. And because I really, understanding that like it's so much hormone therapy is going to definitely get to you
yeah.
to a place that you weren't before. But
Mm,
the whole picture of health in midlife is so much more than hormone therapy. Hormone therapy is just
Yeah.
one part of,
Hmm.
understanding how that we probably need to exercise differently in midlife when we're losing our muscle and we have to work harder to
Yeah.
maintain it. Understanding we have to eat differently, including more fiber and protein, and really understanding that like without those other things, without learning how to build muscle, without learning how we have to kind of sometimes change our diets a little bit, you're only going to get part of the health that you're looking for. So women,
Hmm.
like, we have a body composition machine, and I put every patient on it, and we see how much muscle they have and how much fat they have. And a lot of women, it's really changed. I mean, I have people working out and lifting weights with the trainer here when they've never lifted weights before. And that is like, makes my heart sing. And so we have women
Amen.
that, we can see measurable progress. We get them on the scale
Mm.
every 2 to 3 months, and you can actually see, like, yes, they've lost fat without losing muscle, or they've gained muscle. And that progress helps keep them going. So people exercise here.
That's amazing. So where is here? Where can people find you?
Here, they can find me on, if they want some free menopause advice, they can find me on Instagram at Kim Einhorn MD. I'm on Facebook as Kim Einhorn. My website is just my practice, the mpcollective.com. And my practice is located in Bryn Mawr on the main line in the suburbs of Philadelphia.
Oh, awesome. I'm amazing. And I'm coming over very, very soon because I need a tour of that gym and the lavender paper, the walls behind you and all that good stuff. I need to get my Zen in as well.
I
So
I am so
this has
excited
been
about having
awesome.
you come talk to my patients about sleep, because sleep is the one of the biggest issues. So I'm so excited to have
Yes.
you here.
I know. I'm so looking forward to it. Well, thank you so much for joining us. This has been so enlightening for me, and I'm sure for everyone that's either right on live here or is going to come and watch it. So I really, really, truly appreciate you coming.
Thank you so much for having me. It's been an honor.
Amazing. All right, guys. You guys know what we put all the links and we'll put it in the notes as well. So definitely go find Dr. Einhorn. She is always on, like literally with such evidence-based information, very digestible, very practical, and I just love it so much. And if you're out there and you're like, well, sleep is still a thing for me, I still can't figure this thing out. That's what we're here for at the Restful Sleep Please. We would be more than happy. We love to work with women in
Oh,
midlife and really
can I
just help
can I
you.
put a plug in for you?
Yeah,
I When I got back, so I received my first. I have sent you several patients. I don't know if they've all called you
they
yet, but when
have.
I got back
Yeah.
your first consult on my patient, I was floored. It was so comprehensive. It was like, it was everything. Like, I think I know, a little bit about sleep, or maybe I realized how little I actually know about sleep, and how you really do such like a multimodal approach. So I have to say hats off to you, and I've told every single patient about that, and they were like, I can't let them
Oh,
read the consult, but I'm like, this is the
yeah.
woman you need to go to.
I can't wait to meet them. I cannot wait to talk. But thank you so much. I'm so happy to hear you got my love note. I pray I
Oh yeah.
spent some time on them. They can sure
That was
that.
that made me realize I need to be writing better consults and sending them out.
Well, thank you again. All right, everyone. This was so good. This is one you want to bookmark, you want to share with a friend, and you definitely want to come back to. I mean, there was so much value that we unpacked here, and I'm just so thankful for you. And until next time, everyone, I hope you rest well.